All right, I'm joined now by Dr. Hartzell Schaff, who we were with recently, and also Michael Borger from Leipzig. Thank you both for joining us. So I've got two fabulous surgeons here, and we're going to talk a little bit about this concept of valvular heart disease as an international sort of forum, not only diagnosis and treatment. Michael, Hartzell made a great suggestion. How are new procedures evaluated in Europe? Because it certainly is different than in the States. Tell us a little bit about that process. TAVI comes to mind.
Well, the CE mark approval process is a little bit more liberal and a little bit faster track than the FDA approval process. Of course, Hartzell can speak more to the FDA process, but it enables products, new valves, new valve repair devices, new approaches to valve therapy to get a quicker approval process and to enable the clinicians there to have a little earlier exposure to some of these innovative techniques. That has pluses and minuses. Right. Sometimes you have something which is definitely revolutionary and definitely beneficial for certain patient subgroups, for example TAVI therapy, and European patients have benefited from the early implementation. But you also have the disadvantages that occasionally there are some products that probably didn't get as carefully examined as they should have been, and there are occasional negative consequences for patients. So it's a little hard to make a general comment whether it's better or worse than the FDA process, but it certainly is different, and it allows us as clinicians probably more therapeutic options to offer to our patients than in America.
What do you think, Hartzell?
Well, I think that's true. Now, my understanding is that the CE mark requires safety, whereas the FDA requires safety and efficacy, and that those are sort of fundamental differences in the way that devices are approved. And I think that TAVI is a good example of the good and the bad of each system. And in my view, the way that valve has been, or that new technology has been evaluated, is really a blueprint for the future. Because doing a randomized trial is one of the first times the FDA in the cardiac surgical area has required that. And I think that sets a good standard for the future. So it's more expensive, it takes longer to do, but at the end of the day you get data that I think you can make better judgments about in terms of the benefit and the costs and so forth. So,
an excellent point about safety and efficacy. Michael, do you think that every time we're at meetings we see these charts of how many people in Europe are having, the percentage that are having, I'm just using TAVR valves. Do you think that enthusiasm or, getting into where it properly fits will play out over time, in other words, or do you think it's just going to increase, that more and more people with significant AS are going to end up with a TAVR type approach?
I strongly believe there's going to be a plateau and that there will not be a continuous increase in the number of TAVI procedures, because we're getting more and more information, especially in Germany. Germany has the highest TAVI implementation rate in all of Europe and all of the world. And as we're gathering more data, we have a national registry there, we're seeing that certainly for low and medium risk patients, it's not appropriate. And there's always balancing forces. There's some people that want to be more aggressive and pushing the envelope and seeing if there's different patient populations which would be more appropriate. But there's also other forces which are saying, look, we have to carefully evaluate the safety and efficacy of these procedures, and certainly in low-risk patients, I think surgery offers a gold standard that TAVI will never achieve.
Yeah, and Hartzell, the flip side is that I think this whole field has really pushed the surgeons to look at newer approaches, not getting away from the excellence. I'm thinking about the direct aortics and all this stuff with new valves coming front. It really isn't it propelling the field in the surgical advances in the treatment of valvular heart disease?
Sure, and even at this meeting there's going to be discussions on the valves that can be put in a simpler way. It's interesting that aortic valve replacement, for all the good that it does for patients, is really done the same way it was 30 years ago. And the notion that we've not made any progress in implantation is interesting, and I think TAVI has stimulated that to have the easier to investigate easier methods of implantation.
Let me finish, and because I think you have a great discussion. The concept of maybe it's always been an international collaboration among, you guys are both very excellent surgeons and well established and well respected. But I think I get the sense now that there's a tremendous amount of international dialogue. Maybe it's the times we live in with media and instant communication otherwise, but really sort of an exchange of data, an exchange of methods that hasn't been in cardiology before. Do you get that across a broad spectrum? Do you get that feel?
I get the feel on the other side of the ocean that the data that gets presented from European working groups tends to be taken a little more seriously now in America than perhaps it was previously, and that people are saying, this new innovative approaches or devices certainly deserve a closer look. And I think that's a positive development. Certainly Europe has always looked to America for leadership in medical research, and I think that will always be the case. But I think now there's more of a mutual dialogue between the two that are, and a mutual respect between the two that's only going to lead to more patient benefit.
Your thoughts?
Well, we see it in our surgical societies, that there's more integration. And whether it's a product of communication or technology, or the fact that we're more global in terms of all areas of our society, I don't know. But I think that what Mike said about being international is true. Certainly our programs in the United States involve Europeans much more than they did in the past, and it's just taken as a natural.
Well, if I go back and look at since when I began cardiology in '75 and look at the difference now, it's not all, just in participation and respect and everything else, it's dramatically different now. And and the benefit is for the field and for the patient. I think that's the thing. So I appreciate both of you, what you do every day, and for visiting with me. Thank you very much.
Thank you.
My pleasure. Thanks, Randy.
See you.